Good evening. My name is Susan D. Garvey, and I'm the Director of Community Outreach at the Kensington Reston. Thank you for sharing your time with us tonight. The Kensington Reston and the Kensington Falls Church are assisted living and memory care residences located in the heart of Reston and Falls Church, Virginia. Our enhanced programs enable us to deliver care beyond what the traditional senior living community can deliver. We are open for in-person and virtual tours by appointment. Please visit our websites, and we look forward to listening to your needs. Now I'd like to introduce Jane Loschutz, Director of Community Relations at the Kensington Falls Church, to go over a few housekeeping rules for tonight's presentation.
Thank you, Susan. We are using Zoom webinar, so your videos and microphones are automatically off. We would like this to be interactive, so please be sure we can answer all of your questions. Please use the question and answer box to send any questions you have. The session will be recorded, and we'll be sending out the link in case you miss anything. Enjoy.
Thank you, Jane. Now I'm pleased to introduce Dr. Sinha, who's a family medicine board certified chief medical officer at Bellevue Medical Partners with over 15 years of primary care and medical education experience. His primary office is located in the heart of Old Town Alexandria. Dr. Sinha, thank you for being with us, and we look forward to your presentation.
Susan, thank you very much. I'm honored to be here tonight. Thank you, Susan. Thank you, Angela. Thank you, Jane. The Kensington has always done a phenomenal job, and I'm very appreciative of you providing the forum so we can get this very important topic out to the general public. If you will indulge me, I will go ahead and share my screen, and we will go ahead and get started. Okay, so today I'd like to talk about depression and what that means and how we have to take care of your health, especially since we're talking about depression in people who are caring for others. So how do we take care of others and not ignoring ourselves at the same time? So I'd like to start off by asking a question. Why is it that you rarely see ambulance personnel running when they're going to see a patient? I'm sure we've all seen an ambulance arrive to a critical emergency. The paramedics get out, but they're usually walking quickly, yes, but they're not running. They're walking briskly, purposefully, quietly. Why is that? In the pre-COVID world, when we used to fly, why did the airlines insist that we put our oxygen masks on first before we help others? So during the pre-flight briefing, they announced that we should not help anyone until we place our masks on first. So that would mean if I was with my 6-year-old son and the oxygen masks drop, I'm supposed to put it on myself before I put it on him, even if he's panicked and scared. Why is that? And then why is it when we teach CPR to medical students, we always ask them, when you're called to the scene of a cardiac arrest, what's the first thing that you check? And 100% of the time, the answer is given, check the patient's pulse. And 100% of the time, they're wrong. The answer is you check your own pulse first. Why is that? Essentially, we're saying that if you come upon a person that is in significant duress, you should check your own pulse first. Why do we say that? Well, we know that emergency personnel, airline personnel, hospital personnel know that unless you take care of yourself, you go from being the caregiver to the patient. The reason why you don't see EMS personnel running is because it raises your heart rate. It decreases your peripheral vision and decreases your situational awareness. and it increases the likelihood of you tripping and falling and getting hurt, all of which would prevent them from helping that patient. It's why trained hospital workers will take a pause before jumping into a critical situation. Taking your pulse only takes a second, but if your pulse is too fast, that means you have to take a deep breath before you help someone else. And it's also the reason why the airlines want us to place the mask on ourselves first. It only takes a few seconds, but the loss of oxygen can cause us to black out. And if your child has his mask on, but you've passed out, you can't really help him. This concept is critically important for anyone who's in a position where others rely on them for help. In some way, shape, or form, everybody who is listening to this talk is a caregiver. Whether it be your spouse, your parent, your sibling, your friend, your neighbor, there is someone who depends on each of us here. So unless we approach caregiving the same way our EMS people, our hospital staff, or our airline personnel approach it, we have the potential to become the patient rather than the caregiver. So what do we want to accomplish today? First and foremost, this should be a dialogue. Now I know we're in a brave new world of Zoom, so it's difficult to see people, but I would love it if this could be a dialogue where you can insert questions into the chat, and I would be happy to answer questions either during the talk or anytime after the talk. So we're going to talk very briefly about some facts and figures about caregiving. We'll talk about some signs and symptoms of caregiver burnout. And then we'll talk about, as a primary care physician, what do we do when we are faced with a patient who may have depression? What sort of workup do we do? And then we'll talk briefly about some treatment options for depression. And then, of course, we'll happy to answer any questions or answers that come along the way. So according to a study by the National Alliance of Caring, in collaboration with the AARP, if we were to place a monetary value on the services provided by family caregivers, it would be in the hundreds of billions of dollars each year. 65 million people are caregivers in this country. They provide care for people who are chronically ill, disabled, or aged family members. That's over almost 29% of the US population. And we know that the average number of hours that a caregiver spends caring for their loved one is approximately 20 hours per week. 13% of caregivers spend greater than 40 hours per week. Almost 75% of caregivers, when asked, have stated that they neglect their own health. That means they don't go to their doctor's appointments, they don't get routine lab work, they don't get medication refills, and they often don't have preventative care. And almost 1/3 of all caregivers said that they feel that they have poor health. All of this has the potential to lead to what we call caregiver burnout. Caregiver burnout is a downward cascade. It is a state of persistent stress that leads to physical, emotional, mental pressure and stress, which we know will lead to a decreased immune system, which will lead to increased illness, and all of that leads to a decline in health. This occurs regardless of your age, your sex, or the ethnicity of the caregiver. It is a common thread of caregivers to feel a feeling of being overwhelmed. Now, the symptoms of caregiver burnout may be very, very subtle. When I have a patient who I know is a caregiver, I always screen them and I ask them about these symptoms and about symptoms of depression. We often see symptoms where people are feeling overwhelmed, or they're worried, or they're not getting enough sleep, or they're getting too much sleep. They're having weight issues, and they're easily irritated and angry with their other family members or at work. They often complain of frequent physical manifestations of headaches and back pain, and there can be excessive alcohol or drug use as well. So since we're talking about caregivers, we know that there are specific risk factors for caregivers to have a higher risk of depression. We know that caregivers who are caring for people with dementia have a 50% more likelihood to suffer from depression themselves. Statistically speaking, women caregivers have a higher rate of depression than men. However, women are more likely to seek treatment. Men are less likely to admit to depressive symptoms, therefore the doctors are less likely to diagnose them. And men are more likely to self-treat, whether it be immersing themselves in work or abusing alcohol. And we know that caregivers caring for military or veteran patients have also a 50% likelihood of suffering from depression. So one screening tool that I often use, because patients will often ask us, how do we know if we have depression? So there's a very quick and easy screening tool that we utilize in our patient visits. And it is a mnemonic called SIG-E-CAPS. So it starts out with S. So I ask the patient, are you having any sleep changes? Are you waking up more often in the morning? Or are you having a difficult time falling asleep? Then I ask them about their interest in things that they're normally interested in. Are they seeing a decline in interest in normal hobbies? And then we ask them about feelings of guilt. Do they feel constantly guilty? Do they have a feeling of worthlessness? We ask about their energy. Is their energy decreased? Are they feeling fatigued or tired all the time? We ask about their concentration level. Are they having difficult times at work? Are they having a decreased level of concentration where they can't focus on tasks that they could have before? We ask about their appetite. Is it increased? Is it decreased? Do they just no longer eat, or they eat very little? And then we ask about psychomotor activity. Do they have difficulty in getting out of bed? Is it very difficult for them to do physical things that they used to do, such as exercise or go for a walk? And then, of course, we ask about any thoughts of hurting themselves or anybody else. It only takes a few seconds for us to ask these questions. But if the patient answers that 5 or more of these symptoms are present for more than 2 weeks, that is a positive screening exam. And that means that we have to have a focused discussion about depression. So let's say that the screening test is positive. So if we have a patient that I feel may have some depression, or a patient comes to us with a family member, or they say that I feel that I may have some depression, what do we do? So as a primary care doctor, the first thing that we should do is we should start off by talking, by getting a very, very thorough history. Specifically, I ask about the extent of their symptoms. I ask about the effect it's having on their lifestyle. Is their job in jeopardy? Is their marriage in jeopardy? Is their relationships in jeopardy? And then, of course, we ask about their medical history, the drug and alcohol history, and family history. Does mental health issues or problems run in the family? Is there a history of drug or alcohol abuse? We also ask about social history. What sort of things do they like to do for fun? Are they still doing them, or have they stopped doing them? All of this helps paint a very important picture about what the patient's baseline level is. After we get the history, the doctor should perform a thorough physical exam. Thorough physical exam in a primary care physician's office should consist of first checking your vital signs, checking your blood pressure, checking your height, checking your weight. Oftentimes, we don't weigh ourselves every day. I've often had patients that come to my office, and when we weigh them, they're shocked at how much weight they've gained or how much weight they've lost, because they felt that they weighed a certain number, but it's been months since they weighed themselves. So getting good vital signs, checking their pulse rate, checking their blood pressure, getting an excellent cardiac and lung exam, doing a very thorough neurologic exam, and most importantly, getting a very appropriate mental status exam. These are all part of the physical exam that the doctor should do at the visit. Now, obviously, there's more of a workup that we need to do, and that's where we start about blood work or about lab work. The reason why we do blood work, unfortunately, there is no blood test for depression. There is no single imaging study, CAT scan, MRI, or blood test that we can do to diagnose depression. What we do is depression is a diagnosis of exclusion. So what that means is that we look for other signs and symptoms that may cause depressive symptoms. We make sure that they don't have any of those, and then we focus on their clinical history. And from that, we come up with a diagnosis of depression. So the purpose of the lab work is to look at different things to make sure they don't have these conditions. We check a baseline kidney and liver function. We check a blood count level, because if somebody has a very low blood count level where they're anemic, that can lead to symptoms of fatigue, and that can mimic symptoms of depression. We check for thyroid problems. An underactive thyroid and sometimes an overactive thyroid can actually lead to symptoms that can be confused with depression. In men, we check for testosterone levels. We check for B12 and folate levels, and then we'll check other lab work as needed based on the person's medical history and the medications that they're taking. Talking about medications, there are side effects to medications that patients are often on. Now, often they need to be on the medications, but it is important to know that certain medications can also mimic symptoms of depression, or they can exacerbate symptoms of depression. One of the more common ones is a type of blood pressure medication called a beta blocker. These medications often can increase the signs and symptoms of depression. The problem is these medications are also very good. They protect the heart, they lower the blood pressure. So we may not be able to take somebody off them if they have cardiac problems, but it often is helpful to know that a medication is actually causing some of these symptoms or exacerbating some of these symptoms. So getting a very thorough workup is extremely important. We're often asked, can we do imaging studies? Can we do a CAT scan or an MRI? And again, unfortunately, a CAT scan or an MRI of the brain will not diagnose depression, but there are certain things that can happen in the brain that can present with depressive symptoms. So sometimes we will do a CAT scan or an MRI to check for bleeding in the brain, to check for tumors, to check for masses. Sometimes we can see atrophy or shrinking of the brain, especially when we're talking about patients with cognitive disorders or dementia. So all of these workups are done to make sure that we are excluding other conditions that could mimic depression. So as a primary care physician, once I have all of this workup, we then bring the patient back to the office and we talk about what the results are. Now, there is a very specific criteria that is utilized by physicians for diagnosing depression. And there are 4 main criteria that we utilize. This criteria is from the American Psychiatric Association. There is something called the DSM-5, and that stands for the Diagnostic and Statistical Manual of Mental Disorders. And in it, it has a listing of every single diagnosis in the world of psychiatry. And for depression, it has essentially 4 main criteria. The first criteria says patients have 5 or more of these symptoms for more than 2 weeks. So depressed mood most of the day, decreased interest, unintentional weight loss, sleep changes, feeling of worthlessness, decreased concentration, or recurrent thoughts of harming oneself. If they have 5 or more of these for more than 2 weeks, then that is a positive criteria. The second criteria is these symptoms should be causing significant duress. And that could mean distress or duress in any component of their life, in their social setting, in their personal relationships, in their work relationships. If they're having any problems in any of these settings, then that's a positive criteria. The third criteria is that these symptoms are not attributable to another condition, such as what we had talked about before, such as underactive thyroid or certain medications that are causing significant symptoms. And then the last criteria is that the patient has not had any what we call manic episodes. If a patient has had a manic episode, then we start to be concerned about conditions called bipolar disorder. Bipolar disorder can mimic depression, but we describe bipolar as the lowest of lows and the highest of highs. So somebody can be very, very depressed for a period of time, and then they can go into what's called a manic phase, where they're extremely filled with energy. They don't sleep for several days. They have a difficult time in focusing, and they're having flight of ideas, and they're talking very quickly. And so those are what we see in patients with bipolar disorder. So if we diagnose somebody with these conditions, these criteria, and we say that, yes, they do have a diagnosis of major depressive disorder, what is the next step? Well, the next step is to talk to your physician. There are different treatment options for different people. And it's important that we say that this is a very broad discussion about the basic treatment options. Some options are better for others, and based on certain conditions that somebody may have, we may want to do certain treatment options or not use certain medications. But broadly speaking, most treatments for depression can be divided into two categories: medication and non-medication. So let's talk about the non-medication first. That is the psychotherapy. What that means is that patients will often benefit from seeing a therapist. Now, one of the pushbacks that I often get is that they say, well, speaking to a therapist is not going to change what's happening, and it may be a very difficult psychosocial situation that is causing a person's symptoms. So the answer to that is correct. Talking to a therapist may not change the situation, but what it may do is it may change or adjust your reaction to that situation. So speaking to a therapist is often the first step that we do. Now, patients will often say that, well, I can speak to a family member, I can speak to a loved one. And that's great. Having a good social support system is extremely important. But we do know that sometimes speaking to an independent person that frankly doesn't know you very well, that gets to know you throughout the visits, sometimes is a better option. Having somebody who is independent and neutral can definitely help. Ideally, the primary care physician would coordinate with the therapist, and they would follow up and reevaluate. The second category of treatment is medication management. And for some people, it may be prudent to start medications sooner and then follow up with a therapist. We use this when we have patients who come in with very severe depression. And oftentimes we will start them on antidepressant medication and then have them follow up with a psychotherapist in 2 to 4 weeks when the medication has started to kick in. Either way, the bottom line is a team approach is needed. One of the biggest things that I see is that when patients come in and over the course of several visits, we talk to them about depression. We say the word depression. We diagnose them with depression. You can see a physical comfort that the patient will have. The fact that there is a diagnosis or a name to the symptoms that they are feeling. The fact that they know that this is something that is treatable. The fact that they know that this is something that they are not the only ones going through is often extremely, extremely helpful. We'll have patients who come in after the initial visit and they'll say, you know what, I feel 50% better just because I'm doing something about it. So the bottom line is that depression is something that is very, very difficult to handle, but we need to tell people that it's not something that they need to handle alone. Oftentimes, just knowing that there's a diagnosis or there's a name to what you're feeling is often something that will help significantly. So this was a very quick 20-minute discussion about depression. And I'd like to open it up to questions. Susan, if there's any questions that you've noticed in the chat, I'm happy to jump in.
Yes, I got a private question. Someone is wondering, Does depression present differently in older people?
It can. It absolutely can. So what happens is in patients who are older, depression can often present with symptoms of forgetfulness, with memory loss, difficult in what we call their executive functions. In other words, patients who are older sometimes can be diagnosed with dementia, but it's actually not dementia. It's a condition called pseudo-dementia, where if you treat the depression, oftentimes their cognition will improve. Now, I caveat that by saying that there's nothing to say that they can't have both conditions. And many times I'll have patients come to me and they're brought by their children or their spouses. And they'll say that, mom or dad just hasn't been the same for the last 6 months or 8 months. And they seem very depressed. And oftentimes there is a little bit of underlying dementia, but there's also a little bit of underlying depression. And if we treat the depression, whether it be through psychotherapy, through medications, or other environmental changes, oftentimes the depression component will improve. And that will actually help with some of their symptoms. And while it may not treat their dementia, it can absolutely improve their quality of life. So patients who are older, who are presenting with depression, often come in because they're worried about other conditions. So it's important to think about everything and not get tunnel vision when we're talking about depression.
Great. Okay, I have another one that was sent. Can you inherit depression?
Great question. So there are, we do know that there's multiple factors that can lead to somebody having any condition, whether it be diabetes, whether it be heart disease, whether it be depression. And the way that I categorize it is that there's essentially two groups of risk factors. One group of risk factor you can do nothing about, and one group of risk factors you can do something about. The group of risk factors that you can do something about is having a healthy lifestyle, making sure that you're following your routine every day, making sure that you're looking for purpose in every day, you're exercising, you're not imbibing in a lot of alcohol or drug use. So those are the risk factors that you can change. And then there's risk factors that you often can't change. And that has to do with your family history, your family medical problems. So the way to look at it is, if I have a patient that has a strong family history of any sort of condition, in this case we're talking about depression, then it's something that we need to discuss and we need to be aware of and need to keep alert for any flags that may pop up. And my threshold for talking to them about depression would be much lower if I knew that they did have a family history of depression. Having said that, having a family history of depression or mental health conditions by no means means that you will have those conditions as well. Oftentimes I see patients whose parents were suffering from alcoholism. And oftentimes these patients will be very, very careful about not taking alcohol to excess or drug use to excess, because they've seen the side effects of what can happen to family life. So having depression in family does not necessarily mean that you will have depression, but it is an important part of your social history that the physician should know about.
There's another one here that's asked, is seasonal depression a real thing?
So there is a condition called seasonal affective disorder. And what that is for various reasons, people's depressive symptoms exacerbate or increase during the times when it's, for lack of a better word, when it's darker, when it gets darker earlier, when it's colder, when we're going outside less, when there's less vitamin D coming from the sun. So winter and fall is very common to see symptoms of depression exacerbating. For seasonal affective disorder, we'll often treat patients with medications, really for just half the year. And then the other half of the year, the patient may not need them. Now we know that even if somebody has depression, there are certain triggers that can exacerbate it, even if they are being treated with it, even if they are being treated for it. So cold seasons, winter, these are all things that we see doctor's visits and patients' visits increase for depression. So there's a definite connection depending on the time of the year and mental health.
All right, and I have another one to read here. Can you speak to the difference between delirium and depression and why delirium is often missed or not diagnosed, especially in older adults? And there's a follow-up to that, so why don't we start with that?
Sure. So, we have a lot of D words: depression, delirium, dementia, and it's very easy to get mixed up. And so that's a great question. So before we talk about delirium, we have to talk about dementia. So dementia is a condition that is unfortunately not treatable 100% at this point. It is where we see a decline in cognition, in memory, often short-term memory. And there's different types of dementia. There's Alzheimer's dementia, there's Parkinsonian's dementia, there's vascular dementia. So that's dementia. And oftentimes we see patients who have a baseline level of dementia. Now, if anything were to happen to them, if they were to get an infection, say a urinary tract infection or a pneumonia, or need a hospitalization for whatever reason, we often can see a significant uptick in symptoms of dementia. And what that actually is that's not dementia, that's actually delirium. Now, delirium can really happen to anybody. So if I have a fever of 104, 105 degrees Fahrenheit, I would probably be a little delirious. I would be confused. I may not be making a lot of sense. I may be stumbling. So delirium can happen to anybody, but we see delirium happen quite often as a sudden acute worsening of a patient's baseline symptoms of dementia. Now, we know that if somebody has dementia and if they also have depression that's undiagnosed or untreated, and the depression is getting worse and worse and worse, that can also cause symptoms that's worsening that can be delirium. So they're all linked together, but it's important to know that delirium is something that is often reversible. You have to find out what's causing the delirium. If it's a fever, you treat the fever and you treat the infection. If it's a pneumonia, you treat the pneumonia. And then oftentimes, once the treatment has been done, the patient's delirium will improve and they will go back to their baseline level of whether it be dementia or cognition impairment.
The second part of this question is, why is delirium so often overlooked, particularly in the hospital setting?
Yeah, that's a great question. And I've worked in hospitals. I work in the outpatient setting. So we all know that healthcare in general is fragmented. So there's multiple answers why things sometimes can exacerbate in a hospital setting. Number one, we now have physicians and care providers who are divided either into hospitalist or outpatient. So oftentimes, the person taking care of the patient in the hospital is not the person who knows them the best. They're not the ones that are taking care of them in the outpatient setting. So that disconnect is one factor. The second factor is oftentimes a patient will be admitted to the hospital in duress. They'll have a very high fever. Often they can have a very severe urinary tract infection or pneumonia. And we know that those symptoms can cause cognition problems, can cause delirium, but oftentimes in an ER setting, they have to focus on reducing the infection, making sure that the patient does not go into septic shock. We also know that when you're in a hospital, it's very, very different than where you are at home. It's impossible to get rest in a hospital. You're always getting interrupted at nighttime. Nurses are doing very important things. They're checking your blood pressure, they're checking your vital signs, they're hanging IV fluids, but it's a very strange place at nighttime. And oftentimes, people who don't have delirium in the beginning can develop agitation and become more delirious as the hospital stay is increasing. And the best approach, in my opinion, is to be aware of those symptoms, first of all, and to use a proactive approach. We're very fortunate that we know more about this, and in many hospitals, there's geriatric teams that are actively involved to just look for signs and symptoms of delirium. They also know that there's certain things that should not be done if it can be avoided. Certain medications should be avoided in the hospital setting that we know can increase confusion and delirium. We know that having things that are brought in from your home to make it more comfortable are important. Simple things like a picture or a favorite blanket or whatever it may be. Things to give comfort to the patient, to allow them to sleep, we know can decrease signs of delirium. But the question that the person is asking is spot on, because we do see delirium and confusion increase in hospitalizations.
Great. Well, anyone else have any questions? We have a nice audience here tonight. We have 15 people with us.
I have a question. Can you speak to the difference between delirium and depression?
Well,
Sure.
Oh.
So the delirium and depression, as we had talked about before, is a little, delirium is an exacerbation, and it's a reversible condition that can happen in dementia or depression. But depression, and for that matter, dementia, is more of a baseline level. So the way I think of it is delirium is something acute that comes on very quickly, and theoretically it's reversible. Whereas dementia or depression, or both for that matter, can be a steady baseline. So any rapid changes, we start to worry about delirium.
Do you think there's a greater acceptance of a holistic approach to minimizing depression through music therapy or through art therapy or group settings?
I think it's getting better, but I think it needs to be more. There is a better acceptance, just even in my relatively short medical career, just in the last decade and a half, that patients who, just a discussion of depression is an easier discussion. We're seeing that there's a lot of information out there, and people are becoming more accepting of it. There's always people who are resistant to feeling that, or to saying that they have depression, or talking about it for various reasons. And it's important to address the motivation behind that. But I think having a comprehensive, or in your words, a holistic approach is the best way to treat any condition, whether it be cardiac disease, whether it be vascular disease, or whether it be mental health. And we know that the mind is something that's extremely complex, and we know that the more active we keep the mind. You talked about music therapy and art therapy. When I go to memory care communities, and I see patients in assisted living communities and independent communities, and I'll see patients initially starting at home, and I'll see that they're very secluded, and it may just be the TV that they're watching all day, and they're really showing signs and symptoms of major depressive disorder. And for different reasons, they sometimes transition to a memory care community or an assisted living community. And then over time, you can see them interact more. You see that they're seeing people who are interested in the same things that they're interested in, music, art, so forth. And then you can often see their symptoms of depression becoming less and less. And it may always be there, but you'll see them smiling more. You'll see them eating more. You'll see them engaging more. So my answer to that is a wholehearted yes. We need a comprehensive, holistic approach to every medical condition, but specifically to mental health.
Great. There's another question here that asks, what about the use of light therapy for seasonal affect disorder or sundowning?
Yeah, so seasonal affective disorder and sundowning. Couple of different, similar, but not exactly the same. But seasonal affective disorder, we do know light therapy is an absolute benefit, which just tells us, the power of the sun. Vitamin D. There's so much that we get from being outside that helps, and we know that in parts of the world where it's dark for several months, several weeks or several months, we know that light therapy is extremely important, ultraviolet light therapy, for both for growing children, for their bones, for adults. So light therapy is definitely something that is important for us to do. Sundowning is a condition that we often see in patients that have dementia. And it happens usually pretty regularly. It can happen almost every day. And it happens usually when the sun is going down, around 4 to 6 p.m. And it's a slow level of increase in agitation and restlessness. And we have some ideas as to what we think causes it, but we do know that sundowning can occur in patients with dementia. So part of the treatment for that is preparing for it, managing it, expecting it. And light therapy is definitely very helpful. It may not be the only thing that we do, but it's definitely very, very helpful in reducing some of those sundowning symptoms that we see in patients with dementia.
That's so interesting because it's before the dinner hour, so you'd think people would be looking forward to eating or gathering or whatever, but that's a real thing, huh?
It is, yeah. It's
Wow.
the phrase sundowning is used it's often used a couple of different ways, but it is a definitive, absolute, real condition that we often see.
Well, I think we could all talk to you for hours. This has been just great. Thank you so very much for joining us. I'm glad that we are also recording this. So in case people didn't have an opportunity to join us tonight or want to go through your answers again or your presentation again, that would be good. But give us a few parting words this January 2021. And we will say thank you to you, but let you take it out.
So thank you. So, one of the things that we have to be very cognizant about is mental health. And 2020 was an interesting year to say the least. What I've said, what I'm seeing, and I say this just with being a little cavalier, but I think there's some truth to it. I say that I feel in the last 12 months, we've all aged about 18 to 24 months. And, the last year has been very, very difficult. Isolation, tremendous loss for many, many people. But for those of us who haven't, for those of us who are here, we know that isolation in and of itself is very, very difficult to manage in any circumstance. But if you put mental health conditions on top of that, it exacerbates it. So we are seeing across the board a increased level of mental health conditions in the last year. And if I can leave people with one word, it's look out for one another, look out for yourself, and be very aware, because if you're not looking for it, it's very easy to be having symptoms of depression, caregiver burnout. It's important to know you're not alone, and there's things that we can do. And sometimes just talking about it is the biggest step. It's the hardest step, but it's the best step that anybody can take. So if I can leave people with that, that's what it would be.
I think that is absolutely perfect. Thank you for spending your evening with us, and for everyone that joined us, thank you so much. And we'll look forward to seeing you next month for another interesting guest to talk on subjects that are on everyone's minds. Dr. Sinha, thank you so very much.
Thank you, Susan. My pleasure.
Have a good evening.
You too. Thank you.